Good afternoon, everyone. We are starting the webinar. So, on the behalf of TM Media, I am delighted to welcome you all to today's insightful webinar on the crucial role of microbiologists in combating AMR. It's truly an honor to host this event at a time when antimicrobial resistance is posing a global threat to public health. As microbiologists, healthcare professionals, researchers, and students, we all play a significant role in strengthening the front lines of this battle. I am especially honored to welcome our esteemed keynote speaker, Dr. Frenil Munim, a highly accomplished clinical microbiologist renowned for his work in AMR, infectious disease diagnostics, and molecular microbiology. With over 15 national and international publications, multiple academic contributions, and clinical excellence, Dr. Munim brings invaluable knowledge and real world insights to this session. Before we begin, a few quick housekeeping notes. Please feel free to drop your questions in the chat box anytime during the session. We'll address them during the Q&A segment. And do stay with us till the end. We promise the session will be both enlightening and thought-provoking. Without further ado, let's dive into today's topic. I now invite Dr. Munim to take us through his presentation on the evolving and essential role of microbiologists in combating AMR. Over to you, sir.
Thank you, Ms. Komal, for the kind introduction. Good afternoon, everyone. Before we begin the session, I would like to thank TM Media to bring such a burning topic and to create awareness among microbiologists how we can help in combating the antimicrobial resistance. Myself, Dr. Frenil Munim, I'm a freelancing microbiologist associated with multiple organizations, and I'm giving services to all of them, which are mentioned here. If I talk about this topic, it is a burning topic. It is being talked since years together. But before we begin, I would like to change the heading of the topic. I would rather say it's a crucial role of a clinical microbiologist rather than just a microbiologist, because when we deal with patients, when we know the clinical history, we can help the clinician in managing the patient, help in de-escalation, escalation, or maybe the target-based therapy. So I have no conflict of interest, and I'll be discussing this topic under the following headlines. First of all, we all should know what is our clinical microbiology laboratory workflow and how it should be, and what are we trying to say through our report to a clinician, because there is a huge communication gap. You tell something, they understand something, and there is a mess. And we'll try to discuss the roles on the case-based discussion. So you will get a message with every case we discuss. So what is the clinical microbiology laboratory workflow? From years together, even when we were studying and our bosses were studying, all the clinicians had only one thing: that report comes very late. It takes around 4 to 5 days, and by the time patient is either dead or discharged. So they always have a doubt, like what we do in the lab. Sometimes even family members think that what do we do, right? So if we go by the classical textbook from our best book, that is Cruikshank.
Voice is breaking.
Is it better now, ma'am? Hello, is it better, ma'am?
Yeah.
Okay. So if we go by the classical textbook from our best book, Cruikshank, it tells that clinical microbiology is concerned with the etiology, pathogenesis, lab diagnosis, and treatment of infection in the individual, and with the epidemiology and control of infection in the community. So technically, if we go back to our MBBS curriculum, so a clinical microbiologist should know microbiology, pathology, medicine, pharmacology, community medicine. So isn't it a big science? So this is something which nobody knows, but this is something which we should know when we are in the field. Now coming to this flow of clinical microbiology laboratory. So when we get a patient with infection, there is sampling. It is done, there is a transport, storage, and labeling. And what once we receive the specimen in the lab, what we usually don't get is a clinical information. We need to fight for that. We need to create awareness for that. without clinical information, it is a crime to report any clinical microbiology sample. So first and foremost thing, if we get the clinical information correct, our job becomes very easy. For example, if you have received a pus sample, but it is not mentioned if it is a liver abscess, then it becomes very easy. You may miss the macroscopy and microscopy part. Maybe you may do a macroscopy, but it may not be a confirmatory, and you may not make a wet mount of that, and you will miss the trophozoites of Entamoeba histolytica. So the report which could have been which could have got ready in just 1 hour or 2 hours max will get unreported technically, because we are not going to grow them, and we'll be just reporting as a sterile pus, but technically we missed the parasite. So with the clinical information, we could have just given the report as early as possible. We can decide the choice of culture medium if we know the exact information. And there are many steps. I would say these are all the checkpoints from macroscopy to microscopy to culture. We need to be on our edge while reporting everything. There are certain areas which can be reported in the first day itself, so that the mentality that our reports are always late will go off. For example, if you are getting a tissue from a paranasal sinus, they may not have asked for it, right? But if they have given the site, you can ask for the test, sir. Why have you not asked KOH? Because many times they are also not aware. If you are finding a pus from the paranasal sinus having gram-positive filamentous organism, so you can just do modified ZN stain then and there, and you can just tell, sir, this can be an nocardia sinusitis, so that they'll understand that the culture will come late, and you can also communicate that the culture will come little late, but you can start the treatment accordingly. So there are certain things which we can suggest them. We are in the era of antimicrobial resistance, so we can offer certain molecular testings as well. For example, if it is a hospital-acquired pneumonia and we have received endotracheal aspirate, we can offer pneumonia panel by biofire, and we'll give the result within 1.5 hours. We'll tell what is the organism. We can also tell what is the resistance gene, so that the antibiotics can be started accordingly. So technically, you are saving 3 to 4 doses of antibiotics, which makes a huge difference in combating AMR, as well as in patient management, as well as the cost to the patient, which is very important in our country. If you see, once you have seen, as I mentioned, the molecular testing which can be offered in the first day, apart from that, if there is a growth after 24 hours, you can suggest if the patient's sample was from ICU and it's having CLAB in the blood, or maybe in the endotracheal aspirate, or in the pus collected operatively, you can suggest expert carbar then and there, or you can start putting your synergy testing as per the CLSI 34th edition, so that by the time your final antibiogram is ready on the 48 hours, you will have the synergy result ready, so that the patient need not, clinician need not wait for one more day, so whether there is a synergy or not. So this is something which you can offer right now, right here, right now, if you have all the checkpoints in your mind, and you can make your clinicians aware accordingly. There are certain biomarkers which can be ordered on the basis of that. For example, you have received a bronchoalveolar lavage and you have seen fungal hyphae on KOH. Just ask the clinician, can I go for galactomana? If it is a contamination or a pathogen, you can decide then and there, because many times in ABPA cases, you may get the hyphae, but patient may not have the invasive infection. So this is something which you need to keep in mind. So remember that these are all the checkpoints you should be knowing before reporting, and you should make your clinicians aware of them. Now, as I mentioned, clinical information. So this is how I used to get initially. So by communication, this is how I started getting it. So this is the blood culture. Previously, they told it is a CBC and you have to just perform CBC and blood CS. But after that, what is the site? What all antibiotics? What are the clinical notes? So this is how I started getting the TRFs. And that's how we are able to correlate. Because as you know, that here the clinician has sent only one blood culture from the right hemodialysis catheter. So I may not be able to tell if I grow something, if it is a CRBSI, or if the catheter is a source, or I am just dealing with the colonizer at the catheter hub. So there are multiple probabilities. So without knowing the entire history, may not be able to tell the clinician. Next time I can tell, sir, you could have collected simultaneous blood culture from two different sites, one from the catheter, one from the peripheral line, so that we can make a diagnosis of CRBSI, or what you can call it, CLABSI, and that can help the clinician to manage the patient accordingly, whether to remove the catheter, whether to put an antibiotic lock solution, or whether to treat that bacteremia with that line only, right? So this is something you can do it by a simple communication. Just talk with them, just tell them that these are the informations I need before I release my report. Okay. Second thing, what we write, because as you know, in our country, we don't have a uniform reporting system, and that may not be there because it varies from individual to individual. So what are we trying to say? What are we putting in our report and what clinician understands? There are certain individuals who write that it was inoculated in the sheep blood agar or macon ki agar and chocolate agar. I guess if you would like to agree with me, then you can think that clinician is not bothered which media did I use, or patient is not going to benefit it, which media did I use. They have sent the sample to me, so I am supposed to use the best possible resources for the patient. So that should not be documented, and no, don't make the report lengthy unnecessarily. So many times what we try to say and what they try to understand. So there is a huge gap. So let us discuss a format that when we get a sample, we have written the name of the sample, what is the site of the sample, and after that we do certain stains, that is gram stain, Zn stain, and in certain cases we do modified Zn stain. As I mentioned, we do wet preparations, especially for urine, because many times there is a discrepancy whether clinician has sent urine routine micro which had pus cells. Now, at that time he prescribed antibiotics. Now he's telling get the culture done. So you may not get the pus cells because of the antibiotic pressure, or you may get the less pus cells. So you better mention about which all, whether you got pus cells in your urine which was received for the culture or not. So it will be easy for them to correlate. Then we mention about the name of the organism. Trust me, nowadays we are getting many exotic organisms which we might be hearing for the first time, and hence the clinician also, because they have studied from the same college where we studied. So you may not, so better to mention them and highlight them. For example, if it is Tinotrophmonas maltophilia or Achromobacter denitrificans from the neonatal blood. So yes, they are the organisms which are coming in, which are becoming rampant in neonatal sepsis. Then we put our antimicrobial testing report, which is actually a very, very crucial part. Some people write zone of inhibition. It depends on the resources available, definitely. Some people write MIC value. Some people write breakpoint to MIC quotient. Some people mention only with dash because they have certain issues, economical issues or whatever. They will write dash in vancomycin, right? Because they have not done MIC. Because you don't have zone of inhibitor, you don't have breakpoint for ZOI. So yes, you will get a variety of you will get different varieties in AST reports. So this is something which I think which makes us different from each other. So here we need to be very, very sure. Some people are mentioning 50 antibiotics, some people are mentioning only 5. So that's the difference. That's where we play a very crucial role. And some of us are writing comments which are hardly read, as everybody knows. So we have to communicate. We have to talk to them. Sir, we have mentioned about that. Why we have not tested it, or why I have reported like this. So we do write a comment below every report. For example, we write about the intrinsic resistance pattern of that organism. That's why we have not reported what we are suspecting. For example, I am isolating E. coli in the urine and the blood of the patient. So I'll write in my blood culture that suggestive of urosepsis. Or if I have received only blood culture and I am growing E. coli, so I will write that kindly rule out gastrointestinal tract and oblique or genitourinary tract as a source of bacteremia. So this is something which I would like to communicate with the clinician, that how E. coli reached there. Is there a source? Is there a focus? So that way you can write your comment. This is something you decide at the bedside. So this is our reporting format. Now coming to this AMR part, I'm not going in so much of detail because so many things have been told. It's a silent pandemic and it's an ongoing war between man and microbes and whatnot. I am not going with the data. If I talk about our country's data, so it is killing thousands every year, but there is no short data from our country because the data collection is not optimum. And how to tackle this in a country like us? Like, how can we do that? How can we contribute that? So we'll start discussing about it. Okay. So if we try to understand our healthcare system of 1.4 billion people, so 70% of the OPD visits and 58% of inpatient individuals are in private sector. So technically 90% of all medicines which are dispensed in private sector and 80% are in private. And if you see in public sector, that is in the central government of central government institutes and 20 of our 28 states, if you see, there are only 30% who are visiting their OPD and 42% IP services. So private sector is catering almost 62% of all India's health infrastructure. Now in private sector, it's a cafeteria choice. Everybody can do anybody can do anything and everything. We have technically no control. There are state to state variations. Some states are doing good for AMS, some states are even not bothered. So because of that, it has created a huge problem. Everybody has their own guidelines and people are practicing more on experience-based medicine rather than evidence-based medicine. And that's why the situation. So how can we, as a community-based microbiologist, help? So who is a community-based microbiologist? Technically a microbiologist who is exposed to all the specialties in the community. I'm not talking about the microbiologist who is there in the institute or in just a corporate hospital catering only 100 or 200 or 500 bedded hospital, but I'm talking about a microbiologist who is in a standalone lab and who is exposed to all the specialties. From a general practitioner to a cardiothoracic surgeon. How? So cardiothoracic surgeon who is a visiting surgeon, for example, who is a visiting surgeon at a hospital, who operates that person there and follows that patient in the OPD. And the patient's wound get infected and that pus swab or that pus comes to a community-based microbiologist. So how this data are being captured? There is no system as such. Now, same way, we are getting exposed to many other specialties like ophthalmologist, ENT. You are getting many corneal scrapings. You are getting many ENT samples, skin scraping from dermatologist, etc. So all this, you are exposed to all the possible specialties. So are your data being captured by the government or anybody? No, there is no network. So whatever antibiogram or antibiotic policy is being generated is only by the certain premier institutes who are reporting to our national authority, and the results are coming. But what about us? What about the ones who are there in the community and they are reporting? So let's start our case presentations. So here is the first case. Very simple case. It's a case of a community acquired UTI. Patient had burning micturition since 2 days. There was no significant past history. Patient went to a general practitioner who ordered a urine culture, and the culture grew Escherichia coli. There was a significant bacteriuria. Patient was symptomatic, and here is the result. If you see here, are you finding something unusual? If you will see, you can see here that ceftriaxone MIC is 4 and ceftriaxone is resistant, and cefuroxime MIC is 4, which is susceptible. So if you see this, so this is going like what we studied in our textbook, that the more higher the generation of the antibiotic, more bigger the spectrum. But what has happened here? The E. coli has become susceptible to a second generation cephalosporin and resistant to third generation cephalosporin. So what made that happen? Who observed that? So technically, a community-based microbiologist who is there in the standalone lab, which is not registered in the network of a national data collection institute, data collecting authority, and he has reported that there is a third generation cephalosporin resistant, and second generation is becoming susceptible. Now with limited resources, which he doesn't know that where to send this, whether he can sequence it or not. So how to manage that? So this is something which is being missed. Now, when this thing happened with me, I went back to literature. I took help of my seniors, and I found out that in Spain they have reported that when there is more use of third generation cephalosporins, especially cefixime or something, then this kind of pattern is becoming prevalent. And when they did the sequencing, there is an ST12 segment which is involved. So that is a detailed part, but this is happening in the community. Now, when the institutes are busy reporting carbapenemases and all those CRAs and all other purine mutations, this is something happening at the community. Imagine your third generation cephalosporin is getting resistant, and which is the most commonly used one. If you check your hospitals, those who are in hospital, if you are checking your discharge summary, and if you're doing the audit of that summary, cefixime, clavulanic acid or plain cefixime are the ones which are commonly used from IV to oral switch, where though they may have ESBL infection, they will be using this, right? So this has caused the problem. So we can be a whistleblower in the community for AMR. We can tell the government, if we are kept in the network, that yes, sir, there is something which I am observing. If we get into the network, we'll come to know whether the isolates which were going to be pen susceptible in the community now developing a resistance. So this is something which we can blow the whistle about. Here comes the second case, very interesting case and very important case. If you see, a 58-year-old male, a known case of CKD, diabetes and obesity, was admitted in ICU with complaints of fever with chills and unconsciousness. So the lab findings were obviously suggestive of infective etiology. Empirical treatment was started by the nephrologist, that was meropenem, teicoplanin and fluconazole, because he was like, patient was in unconscious, it's an emergency. So he started all the three. He tried to cover everything. Now, microbiological findings, he could hardly pass some urine, but whatever he passed, there was no growth. And blood culture, only single bottle was sent, which flagged positive after 24 hours, revealed gram-positive cocaine clusters. So as you mentioned, as you all know, it is a Staph aureus here, beta hemolytic colonies on C blood agar. But what do you think? It's a contaminant or pathogen? Why single bottle? If it is a single bottle, it can be a contaminant and it can be a pathogen. Maybe patient is having ESBL E. coli and I have just isolated skin flora, which is a Staph aureus. So what to do? So this is something where our role comes. Sir, you could have sent a set of blood culture, because patient is of CKD, patient will have HD catheter or maybe DLC line in place. You could have sent us a paired culture, one from the line, one from the periphery, so that we could have identified whether it is CRBSI or CLABSI, and that the diagnosis could have been much more easier. Now, we require this clinico-microbiological correlation. Imagine I am testing this Staph aureus. I am considering it as a pathogen because I don't have anything else to test. So what will you do? What will I do? Now, if you see, we have discussed about this part because a paired culture could have helped us in calculating the differential time to positivity. But now the drug of choice, what will you recommend? What to do? As per the IDSA guidelines, if it turns out to be MRSA, the drug of choice will be vancomycin, and it was an MRSA. So vancomycin is a drug of choice. For now, if I have only zone of inhibition, means I am just doing this diffusion testing, how will I check for vancomycin? As there are no breakpoints since last 8 to 9 years. So I am left with only MIC. So I have to tell my clinician that, sir, for this, I'll have to check for MIC, or you have to develop that test in place. If you have automated machines, you are blessed. But if you don't have, at least develop certain tests. So develop this test for certain antibiotics, because slowly and steadily, if you will see the CLSI, the zone diameter breakpoints are slowly fading away. So MIC testing is a must. So what all messages you could have given? Just like if you see, you can tell your clinician that even if for strep pneumo, I don't have a zone of inhibition breakpoints now, we can just report MIC. So this is a need of an hour. You can discuss them. How do you interpret that? How do you calculate the BMQ? on the basis of this and how not all numbers are same for all the antibiotics, because when you will start reporting this, you know what hurdles come, because less than equal to 1 for cefepime is a very good breakpoint. It is susceptible, but when it is 1 for ciprofloxacin, it is not a good breakpoint. So all the numbers are not same for all the antibiotics. So this is something which you can calculate by explaining them that 4 for amikacin and 4 for gentamicin are different. If you have 4 MIC of 4 for both, amikacin is a superior choice compared to gentamicin, because gentamicin is just a one-fold away to become intermediate. So this is something which you have to create. You have to create awareness about optimum sample collection. As we mentioned, you tell them that, sir, it will be great if you can give a paired blood culture. You can, by doing that, you can help a clinician in establishing the diagnosis, whether it is a CLABSI or it is a different source, maybe a cellulitis causing bacteremia and there is no DTP. So like that, you can tell whether the DTP is positive or negative. You can promote a right testing method. Tell them that, sir, MIC testing has to be promoted. It is little bit a costly affair, but that's the only testing method through which I can generate an authentic report. And on the basis of your report, you can always suggest de-escalation. Sir, you can stop your meropenem now. You can adjust your teicoplanin dose as per renal function, and the drug of choice will be vancomycin, as teicoplanin data is not available from the Western world. So if you want to switch to vancomycin, do that and suggest vancomycin trough level after certain days. So and definitely you can ask them to stop fluconazole as well. So that way you can help your clinician to de-escalate as well. Coming to the case 3, a 72-year-old male who is a known case of hypertension, diabetes mellitus, and ischemic heart disease, who is obese, was received in emergency room with hypoxia, fever, coughing since 3 days. He took injection clarithromycin, piperacillin, tazobactam, and tablet oseltamivir somewhere else. At ER, his CBC was within normal limits, CRP was raised, chest X-ray showed pneumonia with effusion, CT scan was ordered. We developed one test which we perform on the platform called CFIT Gene Expert. So we ordered a flu panel, which is a protocol in a hospital where I go, that in emergency room only you order this flu panel and see what it is. To our surprise, it was RSV. It was respiratory syncytial virus. So whatever we were giving, whatever he was receiving, to be honest, was of no use. So patient was dealing with respiratory syncytial virus. So here it was a viral pneumonia. Now, if you see what made a difference here. So by introducing this test, we make the result available in 45 minutes, because the test running time is only 35 minutes. So while the patient's file is getting ready, we collect the nasopharyngeal swab and perform the test. We disseminate the result by functioning 24/7, which is very important, through WhatsApp, SMS, and phone call to a treating clinician, emergency room registrar, and definitely ICN, because on the basis of that, you can decide whether to isolate the patient or not. So it's a complete teamwork. So by introducing a good test, you can make a huge difference. Now, why should you introduce certain tests? Because if you meet your clinician, your pulmonologist, there are a lot of confusions going on. Here you can see there are 4 different X-rays of 4 different individuals. First X-ray is of 42-year-old pericardial effusion, 57-year-old left pleural effusion, 52-year-old right middle lobe pneumonia, and 62-year-old bilateral ground glass opacities. So what are these? If you check them, they were all human metapneumovirus. The presentations can be varied. If they are not checked in time, some people will start AKT for somebody. Some people will start multiple antibiotics considering a community-acquired pneumonia. And some people will start even antivirals like oseltamivir in certain cases if the season is of flu, or if he or she is seeing many of the flu cases. But technically, nothing is going to work. It is human metapneumovirus. So you are going to give only supportive treatment. So by introducing a good test, you can diagnose and you can help your clinician in managing the cases. So what I have observed at my setup, that there is a good side effect of COVID. Majority of viral pneumonias are named now. As I mentioned, how previously, when even I was studying, we had filled so many discharge summary with query viral pneumonia, and those patients received what not, ceftriaxone, levofloxacin, doxycycline, azithromycin, many things. But we didn't know whether those viral pneumonia were really viral pneumonia, because we never diagnosed because of the lack of resources, or our bosses never were interested. Now there are a lot of platforms available for testing. Clinicians are also offering them, and patients are opting them. It's your time to tell the clinicians that, sir, these are the platforms where I can help you out to diagnose your case. So it is a need of an hour to combat AMR. You can stop unnecessary antibiotics if the diagnosis is in place. So diagnostic stewardship and hence antimicrobial stewardship is possible only and only if you have your diagnostic stewardship in place. So what is this syndromic testing actually? So how the, like you saw, we checked four pathogens in the panel, that is flu A, flu B, RSV, and COVID. So if you see, syndromic testing is a symptom-driven broad grouping of probable pathogens into one, and there is a rapid test which maximizes the chance of getting the right answer in a clinically relevant time frame. So technically it is like this. Previously we used to get one sample, multiple tests used to be ordered, results used to take hours to days, and patient had to stay for long in the hospital. If you do a syndromic testing, if you know a syndrome, you just check one sample for that one comprehensive test. The results are available in just few hours, and the report is available to patient, and the patient can be discharged early if the targeted therapy can be started. So here comes our routine practice. What we do usually, there is an admission of a patient, there is diagnosis is yet to be made or you have made, and there is empirical treatment. You have ordered certain tests, you have modified the treatment. Now again there is a new event, again more test, retest, then there is MDR, then you modify the treatment. So this entire process, you require antimicrobial stewardship at every point, but what you require is a diagnostic stewardship continuously, that which test to be offered at what stage. So this is something which you can need to communicate. So diagnostic stewardship is what? It's a right test for the right patient at the right time, along with a right interpretation plus right communication. So this is a very good definition in JAMA about diagnostic stewardship is modifying the process of ordering, performing, and reporting diagnostic tests to improve the treatment of infections and other conditions. So here goes the message: offering the right test for the right patient at the right time. That's your diagnostic stewardship, and that is a main cornerstone, I would say, to combat AMR from a microbiologist side. Now coming to the case 4. If you see, this was a very interesting case, because as you know that we have more of nursing homes and less of corporate hospitals or premier institutes at every city, sparring few in our country. So this was a 37-year female who had a mass over thigh since 1 month, which was increasing in size. After almost 1 month, it became static. USG suspected its query malignancy. There was no conclusive evidence. So surgeon decided to excise it. He sent it for histopathological examination, bacterial culture, and fungus culture. Histopathology revealed fungus, which they reported as a query, or maybe it was like a mucormycosis. That's what they told. And the cultures were sterile as of now, and surgeon was ready that I have done the excision, I'll give some antifungal coverage, and surgeon did the skin grafting. Skin graft got infected by ESBL clap because it was on the thigh, so maybe some contamination happened and the graft got infected. By the time when we saw the gram stain, we also found certain fungal hyphae, and which grew on the 8th day. On detailed examination, it turned out to be Basidio-Bolus ranarum. So technically, the surgeon who gave amphotericin B for this many days, and apart from that, he gave flucytosine also, but nothing was working. Simple potassium iodide saturation salt solution could actually cure the patient, and it was the cheapest possible treatment available for the patient at that time. But so here, if you see, limited resources are not always limited. You need to be very cautious, and you need to be aware of all the things, all the etiologies which are there in by the nature. So simple microscopy and basic setup can help you diagnose the rarest possible cases as well. Here is a case 5. A 68-year female presented with blepharitis to the ophthalmologist OPD. She was using moxifloxacin drops, which was given to her by the pharmacist over the counter. She was not responding. On examination, there was severe inflammation of the eyelid. Ophthalmologist suspected something weird because patient had a poor hygiene. He called the microbiologist whether he can help in finding the mite. I was like, I have never seen mite, but yes, you can send your sample. So the ophthalmologist sent me the eyelash and just a saline mount, and I could found Demodex blepharitis, Demodex follicularum, which is a mite which causes Demodex blepharitis. So there are certain things which we can do with our simple microscopy. So don't underestimate it. We can stop moxiflox eye drops then and there, and tea tree oil or maybe ivermectin could have helped. So patient was managed with the right drug, and unnecessary medications can be avoided. These are also the areas where antimicrobials are using, and they are ignored areas. Nobody is having a track of them. So these are something which you can, where you can achieve your stewardship by offering the right test. Coming to the case number 6, there is an infertile female who delivered twins with IVF, and after IVF, she was having recurrent breast abscess. She got... Hello? Yes? Yes, ma'am? Hello?
You can continue.
Yeah, okay. So she was having a recurrent breast abscess. Now, for that, she received multiple antibiotics. Even one of the surgeons started AKT, considering the previous surgery report telling it is a granulomatous mastitis. They performed mammography. Radiologist told query hamartoma, and patient got quite anxious because they thought it's a cancer. This time, the surgeon did entire lumpectomy, and histopathologist reported granulomatous mastitis. But some pus was sent for microbiological culture. Culture grew on 6th day, query Corynebacterium species. Now, which is something quite unique to us. When I told my histopathologist that I have grown that, we both went to literature and we found out there is an entity called cystic neutrophilic granulomatous mastitis. We convinced the patient, we sent the isolate for mildly of identification. It turned out to be Corynebacterium amicolatum, and that's how we could establish the diagnosis of cystic neutrophilic granulomatous mastitis with, a teamwork, with interdisciplinary teamwork, you can say, so that we could label the patient that you don't have any hamartoma or tumor. This is a different kind of mastitis for which you require a certain treatment. So this is something which we can always do when we have certain case scenarios, like prolonging the incubation of our cultures, and we can get the definite diagnosis by growing that particular organism. So here is my take-home message to all the microbiologists, that community-based microbiologist microbiology practice can make a huge difference, because you are exposed to multiple specialties and multiple cases. Those patients who have been operated in the hospital and they are coming to surgeon's OPD, sending you the swabs and the pus which are having MDR organisms. So you may get confused that MDR coming from the community, but it is the organism from hospital which is coming to the community. So we have a diverse healthcare situation. We can be the whistleblower of impending AMR, as I mentioned in the first case. So this is something which I would like to address here, that our textbook, our famous textbook used to say that organisms do not read textbooks. So here the bacteria didn't read the textbook that I am a third generation. I don't need to be they don't need to get resistant to directly third generation cephalosporins and can remain susceptible to second. But yes, it is happening. It is a reality now. So we need to be very cautious while reporting. And only way to combat this AMR and achieving the antimicrobial stewardship is to promote diagnostic stewardship and nothing else. You need to be on your toes. You need to be there for your clinician to suggest the right test for the right patient at the right time. We cannot sit at the bedside just like that and giving the report. We need to communicate, if possible, see the patient, get the complete history, and then release the report. And last but not the least, this guy had a license to kill, and we have the license to prescribe antibiotics. Let's use the antibiotics judiciously because we are left with very few. Thank you.
Thank you so much, Dr. Muneen, for that enlightening and deeply informative session. Your insights into antimicrobial resistance, clinical challenges, and the future of microbiology have truly enriched our understanding. Okay, so everyone, we are starting the Q&A round. Please drop your questions in the chat box. Okay, we have received our first question. What quality control measures are most critical for reliable AMR detection? Just a second. AMR detection in a clinical lab.
So, first and foremost, make sure that you are running your QC strains as per your workload. If once a week or every 15 days, so you should be knowing that your QC strains or your methods are methods are working optimally. Apart from that, develop certain test. For example, a synergy testing. I could have put a photo which I actually missed. That the synergy testing, when you don't have any molecular assistance, you don't have expert carba or something, but your consultant is asking whether this ceftazimab bactam plus aztreonam will work or not. So this is something which you can develop in house. You have the clear cut guidelines from CLSI, and you can develop with that. If you ask me how I have developed, so apart from those 4 tubes which has been recommended by CLSI, I put one media control as well, just to check whether my media is not contaminated. So this is something you need to see when you are reporting certain MDR bugs to in your report. So these are all the measures you are supposed to take, sir.
Okay, so we have our next question. What are the most common pathogens showing resistance trends in hospital settings today?
Uh, Almost all. I would say most common pathogens are Klebsiella pneumonia. It varies from institute to institute, to be honest, but that's yes, this and CRE. Then like carbapenem resistant Kleb is the major one. Apart from that, we are also getting E. coli, which is also CRE. Then Acinetobacter with Baumannii, Pseudomonas, and definitely MRSA. But MRSA, I would say, is more in the community rather than in the hospitals.
So our next question is, what role does molecular diagnostic technology play in AMR surveillance?
If it is available, it plays a huge role. It plays a huge role, but the only problem is it's not available with everybody, and we have a huge load to test also to go to test for that also. But definitely, if you have a molecular techniques, you can your turnaround time will go quite down, and you can release the report as soon as possible. If you see that. Like you are in an institute and you have biofire in place, so as soon as your blood culture comes positive, you can just run the blood culture identification panel, and you in 2 hours you will come to know which organism it is, along with the resistance gene as well. So this is something this is something which makes a huge difference in patient management. Your antibiotic, imagine the antibiotic doses you save. For example, you don't have that machine in place. Now that blood culture has been processed, after overnight incubation, you are getting a growth, you are running the AST, again taking 1 day, and then if it turns out to be carbapenem resistant, you are putting a synergy testing, or you are going for expert carba. So technically, you have saved almost 5 to 6 doses of antibiotics by introducing one test at a time. So yes, it makes a huge difference. It makes a huge difference.
So our next question from Mr. Prashant Singh is, AST reports with plus, and you can check it in the chat box. How will you
Yeah.
interpret it? Which antibiotics is
They cannot be interpreted. Those reports are not reliable. You can just change the lab rather than interpreting the report.
So our next question is, what key performance indicator should lab tracks to assess their impact on AMR reduction?
Key performing indicators, if you see, rather than a lab, I would say the lab in a hospital should keep. First and foremost is the rate of MDROs in the hospital. the percentage MDROs. You can just generate your antibiograms periodically and make them available on your hospital dashboard, or you can just tell with the clinician or circulate it among the clinicians. Apart from that, you would have you would have an antibiotic policy with that. So just see that percentage antibiotic compliance. Apart from that, if you are having a team of clinical pharmacists, so there are many other KPIs which can help you to come up with establishing AMS and curbing the AMR. For example, defined daily doses. You have DOT, that is duration of therapy, length of therapy, all those KPIs which can be calculated with the help of clinical pharmacist.
Thank you, sir. Our next question is it is yeah. What are the challenges in interpreting susceptibility results for multi-drug resistance organisms?
There are no more challenges. Actually, everything is becoming resistant now. But yes, by knowing certain patterns, you will come to know. Suppose you don't have an automated system, but by if your quality checks are in place and you are getting all those carbapenem resistance, your ID is correct, so you can say that it is a carbapenemous producer, and you have multiple methods available in CLSI, which you can choose one for your setting, which is which is useful for your setting and which is feasible with you. You can establish that, and you can report that for ESBL testing, for MC testing, for MRSA, for high level gentamicin resistance, D test. All these tests which are there in the CLSI should be a part of your testing strategy. So I think there won't be any such problem. And as the newer one, that is synergy testing, which has been introduced since last 1 year, and before that we used to follow paper of Dr. Balaji sir, which was published in IJM. So now you can shift to synergy testing, establish that at your place, procure Mullarentin broth and run that. It is easy test, disk elution method. You can do that. Even for colistin testing, you have elution method available now. So establish in your lab. So no more challenge, no more challenge as such. Then there is one more. If third generation cephalosporins are resistant, do we need to report first and second? See, that's what we learned in the textbook, but that's not true now. You can report first and second generation because, as I mentioned, the bacteria are not reading the textbook. The mutations happening in the community level are beyond our knowledge if we are not aware. But yes, the first second generation can be susceptible, and third generation can be resistant in an isolate. Which reference guideline to follow environmental monitoring in hospital environments, and are there any limits as per the critical areas? Yes, there are guidelines by CDC. There is a textbook available, Miss Swati, Miss Swaroop, Mr. Swaroop Poddar, and that is available. You can just follow them for environmental monitoring.
Anyone, if you have any question, please drop it in the chat box. Okay, so I think we are done with the Q&A session.
Why microbes, MTP or MDR? What is the exact mechanism? MTP are becoming MDR because of the mutations. Because of the mutations, Shardam. Those mutations are to be checked. And there is a huge problem because, as you know, previously we used to have the alternate day AKT. Now we are going for the continuous AKT. So I think all those measures have created a chaos among the MTP. So yes, they are MDR. The mechanism is through mutations.
We'll wait for 1 minute, and if you all are done with your questions. I would like to thank each one of you for your active participation, questions, and engagement throughout the webinar. Thank you so much, Dr. Muneen, for this knowledgeable session, and it was very great to be a part of it. At TM Media, we are committed to empowering microbiologists and advancing microbial practices through innovation, education, and collaboration. So, if you found the session useful, do share your feedback with us. The link is in the chat box, and a recording of the session and participation certification will be shared shortly. We have one more question. Phosphomycin can be reported in Klebsiella?
Phosphomycin, see, the breakpoints available in CLSI is only for E. coli and not for Klebsiella. But yes, people are extrapolating those breakpoints for Klebsiella and reporting it, especially report that in urine for other osteomyelitis and other cases. Yes, it is being used, but encourage IV phosphomycin and not the sachets which are available. That is, they are only for urine.
Mr. Prashant, this webinar will be available on the TM Media's YouTube channel. You can search TM Media on YouTube and you can follow us on our LinkedIn, Instagram channels for the presentation and the recording.